I will tell you how to interpret ABG. ABG stands for Arterial Blood Gases. Arterial blood gases, as you know, it is an important measure to know the ventilation status of the patient, and it is most often used in the ICU, intensive care unit, for the change of the ventilator setting or need for mechanical ventilation for a patient. The first thing to be checked in the ABG report is the pH of the blood. pH, the normal range is 7.40 plus minus 0.04. It means if pH is less than 7.36, then it is acidosis, and if pH is more than 7.44, then it is alkalosis. It is very easy that normal range of blood pH is from 7.36 to 7.44. So the first thing to be checked is the pH. Then second thing to be checked in the ABG report is the PCO2, that is the partial pressure of the dissolved carbon dioxide in blood, and it is to understand what is the primary cause of this acidosis or alkalosis. The normal range of PCO2 is 25 to 40 millimeter Hg. There may be slight variation in different books. Somewhere it is written 26 to 42, but it is just for reference and easy to remember. I am giving you the example that is a 25 to 40 mmHg. So in the ABG report, first thing you see the pH, then if it is acidosis or alkalosis, then second thing should be seen is that the PCO2. If PCO2 is more than 40, it means there is a respiratory acidosis. The diagnosis is definitive that it is because of the retention of the carbon dioxide, and that leads to respiratory acidosis. What are the common cause of the respiratory acidosis? That is the hypoventilation, that or any lung disease, or the respiratory suppression because of the opiates or sedatives. So, and if it is the PCO2 is less than 40, then it is metabolic acidosis, and there will be, it is because of some compensation. Okay, I will tell you about the compensation later. But first thing, as I told you, first you see the pH, then second you see PCO2. Then if the PCO2, if you find the pH is more than 7.44, then if the PCO2 is less than 40 millimeter Hg, therefore it shows that patient is hyperventilating. It is very commonly seen in the emergency setting that most of the patients, they hyperventilate and they wash out the carbon dioxide outside, and which leads to alkalosis. And if alkalosis is there and pH is more than 40, then it is because of the metabolic cause, and there may be some compensation. And the common cause of alkalosis because of metabolic cause is the vomiting or diuretic use. Okay, then it means just by seeing the PCO2 you can diagnose the respiratory acidosis and respiratory alkalosis. Respiratory acidosis because carbon dioxide leads to formation of carbonic acid, and as it is acid, it leads to acidosis. Okay, if it is less, then there is alkalosis, and this PCO2 is less than 40, it means it is because of the respiratory cause. Okay, then another thing one should know, that sometimes because of in the ventilator setting, the fraction of the inspired oxygen, that is called FiO2, if it is set as a very low level, or patient is hypoventilating, or patient is not making enough efforts, it means there is a less intake of the oxygen, and that is called hypoxia. There is less oxygen. So you should see what level of oxygen is there in the blood. So normally it is 80 to 100 mmHg, 80 to 100 mmHg, and it is a range. There is another unit that is called kPa, 10 to 13 kPa. In some books kPa is written, okay, but normally 80 to 100 mmHg. It means if the blood oxygen, dissolved oxygen in the blood is less, it may be because of the less oxygen, therefore you provide the oxygen support, or if patient is on ventilator, you increase the fraction of inspired oxygen, that is normally 40 or 60, and while doing suction you sometimes put it as a 100% also. Therefore you see the PaO2. Third thing, one is the pH, then PCO2, then PaO2, that is 80 to 100 mmHg. These things are very important in neurosurgery, in neurosurgical patients, because there is a term called elective hyperventilation. Elective hyperventilation is given in the patients where there is a raised intracranial pressure, and there is a relation between the mean arterial pressure and ICP and cerebral perfusion pressure. It means cerebral perfusion is equal to mean arterial pressure minus ICP. So aim is to decrease the ICP in all patients where the ICT is raised. In head injury patients or after the surgery, there is ICT is raised. Sometimes we put the patient on ventilator with an aim of keeping the PCO2 less than 40, and it is usually kept at the lower level, that is the 25 mmHg, around 25 mm, 26 mmHg. Therefore it causes the vasoconstriction and it leads to reduction of the ICT, but it should not be less than 25, because of the vasoconstriction there may be ischemia. So it is the rationale behind the elective hypoventilation. How you can set the elective hypoventilation? That put the patient on sedation or patient on this deep sedation, or make the patient unconscious by giving Norcuron or these agents, and keep the patient on continuous mechanical ventilation for 24 hours or 48 hours, and keep the respiratory rate, which is normally 18, just for remembering, 18 to 20, you just keep it around 16 or 14. Therefore it causes the respiratory rate, or you increase the respiratory rate. Suppose you increase it to 20, it means there is a hyperventilation. If there will be hyperventilation, there will carbon dioxide burst out, and this PCO2 will in the ABG it will be close to around 25, 26. So it is called elective hyperventilation. If respiratory rate on continuous mechanical ventilation is put on the higher side, that is around 20, then it is called elective hyperventilation. Okay. Then third thing, now the respiratory acidosis and respiratory alkalosis, a diagnosis is very clear cut just by seeing pH, then PCO2. Just to you see the two parameters, you can diagnose respiratory acidosis and respiratory alkalosis. Then you see the PaO2, that is a partial pressure of dissolved oxygen in the blood. You can make out the diagnosis of hypoxia. Then you just increase the oxygen supplementation. Okay, and when there is a metabolic acidosis, it means the carbon dioxide, PCO2 is low, but still patient has acidosis. This means it is because of the bicarbonate ions, which ranges from 22 to 28. Sometimes it is written 26. Just you remember one that like 22 to 28 millimeter Hg. Low bicarbonate ion, it shows metabolic acidosis. Suppose it is less than 22, it is because of the metabolic cause there is acidosis. Or if it is high, it is metabolic alkalosis. Therefore, if pH is say less than 7.46, you saw the pH and you found PCO2 is less, it means the cause is because of the metabolic cause, and in metabolic you find here bicarbonate ions are less. It means because of the metabolic acidosis there is a this acidosis is because with less bicarbonate ions. Okay, and if bicarbonate ion is less, just to compensate that, there is a changes in PCO2 secondary to this, therefore it is called compensation. It means metabolic acidosis with compensation. If it is because of the metabolic cause, then respiration is tries respiratory rate, or with that patient tries to compensate with that. Similarly, if bicarbonate is more, then it is because of the metabolic alkalosis. Then one term you might be hearing, that is the anion gap. What is the relevance of the anion gap in ABG? It is, anion gap is normally there are cations and anions. The predominant cation is sodium, which is plus charge. So sodium plus, potassium plus, and these are the normal cations, and anions are chloride and bicarbonate. So you just add this sodium, and sometimes it is said that potassium concentration is very less, that it may not be calculated, but in some books it is written that it may be added. Thus anion gap value will just increase, but normal anion gap is 8 to 12 millimeter equivalent. It means you measure the sodium plus concentration, sodium, subtract it with the chloride and this bicarbonate. Suppose sodium concentration is 137 milliequivalent, bicarbonate is 24 milliequivalent, and chloride is 102, then anion gap will be 11 milliequivalent per liter. It means it is within the normal range. What happens? Just check the anion gap. If there is a very high anion gap, it means there is a metabolic acidosis, but with a high anion gap, then it indicates the diagnosis of renal failure, lactic acidosis, diabetic ketoacidosis, and salicylate toxicity, that is the aspirin ingestion. And if it is a normal anion gap, then it is because of the diarrhea and renal tubular acidosis. Therefore, to summarize that, ABG is a very simple investigation to interpret. It is very commonly done, and everybody should be aware about this, because it helps in the making the diagnosis. It helps to decide the ventilator setting. Like if patient is having carbon dioxide reduction, okay, if acidosis is there, you have to increase the rate of the mechanical ventilation. Therefore, only just you memorize normal pH value, that is 7.40 plus minus 0.04. Next thing should be memorized, that is the PC. It is called PCO2, that is 25 to 40 mmHg. Third thing you should know, that PaO2, that is 80 to 100 millimeter Hg. Then bicarbonate ion concentration, that is 22 to 28. And just for the completion of the knowledge about this entire thing, you just memorize the normal anion gap, that is 8 to 12 milli equivalent. And in the renal failure, lactic acidosis, diabetic acidosis, there is a very high anion gap, and but normal anion gap is seen in diarrhea and renal tubular acidosis. That's all for ABG. Thank you.